Bună ziua. Hello to everybody. Can you hear me?
Yes, hello.
Okay. I will begin to share. I will ask you if possible, except when I ask you or you want to say something, to close your microphones so that we don't get any echo.
I have a question, if I may.
Yes, please.
Are we allowed to record a meeting?
You can allow this lecture, but you are not allowed, of course, to share it on any type of platform other than for your own use. Okay?
Yes, I will record it and I'll share it to my colleagues.
Okay.
Thank you.
Okay, do you see the PowerPoint now? The first slide?
Yes, we do.
I will put it in slideshow and I will ask you just to confirm that you see it in slideshow and you see the second slide now. Do you? Do you see
Not yet.
title and second slide? It's not yet in slideshow?
No, not yet.
Okay, then I'll do it again. Let's see. Okay, maybe now. Do you have the first slide and now the second one?
Yes.
Okay, then I hope it will work. Okay, so there was, as you might know, a lecture switch due to the fact that Dr. Beladan is on call today. So we are discussing now infective endocarditis. It was the lecture from tomorrow, which, okay, it would still make sense because it is still in the direction of valvular heart disease. Infective endocarditis is a very dreaded complication of mainly of valvular heart disease, because it is an infection of the endocardium of the valves in general, much more rarely the endocardium of the walls of the heart, which can still happen when there are defects of these walls, like, for example, a ventricular septal defect, or less often an atrial septal defect, or sometimes it can also happen as an infection of the endothelium of the arteries, like, for example, if there is a turbulence in an aortic coarctation or a patent arterial duct, so in abnormal regions of arteries with stenosis, and then it is called endarteritis. So endocarditis is an inflammation, and infective endocarditis is an infection of the endocardial surface of the heart in general. And the representative lesion is consists of vegetations. You can see in this drawing on the side, if a normal healthy valve is a smooth structure, in an infected valve, there could be on the surface of the valve, on one of the cusps or several cusps, small vegetations. You will see echocardiographic images, and you will understand that these vegetations might be very small at the beginning, but usually grow to be quite large. I said it's a dreaded complication of valvular heart disease because the mortality rate of infective endocarditis is quite high, even in the antibiotic era that we are living in. It's 20 up to 25%, and the reason is that the diagnosis of infective endocarditis can be difficult and sometimes takes some time to be obtained. In about 3/4 of the cases of infective endocarditis, it appears if there was already a valvulopathy, a valvular heart disease. It can be mitral regurgitation, it can be aortic stenosis, it can be tricuspid or pulmonary problems. As I said, it can be congenital heart disease, mainly ventricular septal defect. It can be something that is a foreign material in the heart, like, for example, valvular prosthesis, or the leads of intracardiac devices, for example, leads of a pacemaker or a defibrillator can also harbor vegetations. However, up to 25% of the infective endocarditis cases can appear on normal heart valves. Still, of course, it needs to have a cause or a context where the endocarditis appears, meaning that even if the heart valves are normal, there should be something abnormal happening. And this something abnormal can be a septicemia, so a systemic infection, sepsis, usually with staphylococcus, because it is quite aggressive to the cardiac structures. Or it can be the situation of a patient who is, for example, an IV drug user, and by using the syringes and the needles for IV drug administration, which often are not very well sterilized, and also the skin is not very well sterilized, allows the entrance in the circulation of microorganisms, so that the even on normal heart valves there would be an infection. Let's say 2 or 3 decades ago, the main cause or the main underlying lesion of infective endocarditis was rheumatic valve disease. Nowadays, rheumatic valve disease is less and less frequent in the population, and more we see endocarditis, as I said, on degenerative diseases, on mitral valve prolapse, which is quite frequent in the population, or aortic stenosis or aortic regurgitation. So lesions which come usually with age. And as I said, due to this more and more use maybe of IV drugs or infections of different types, normal valves can also be present more than it was the case before. In order to have to obtain, let's say, to have the vegetations appear, there needs to be some local abnormality, which the first one would be the endothelial injury. Because if the endothelium is injured, then there is an effort of the organism to repair this injury. And that is the place where the vegetations would appear. And generally, the vegetations are more prone to appear in valvular regurgitations more often than in stenosis. However, we can see patients with aortic stenosis and vegetations, and it is not so rare. And then vegetations also tend to develop where the blood goes from a very high pressure area through the orifice in a lower pressure area. And this is the case on the mitral valve. We usually have the vegetations on the atrial surface of the mitral valve. And on the aortic valve, you could have the vegetations more often on the ventricular side of the valve. Of course, there is no rule in medicine that does not have exceptions, and this is just something to orientate us in order to say this mass on the valve could more probably be a vegetation than something else. And I said that there needs to be an endothelial injury as a basic lesion, let's say, because the normal response of any organism would be to repair this injury. And in order to repair it normally, there would be platelet deposition together with fibrin. So there would be, the organism would try to, cover it with a sort of a clot, a platelet clot. But if in the meantime, in the blood, there are microorganisms, especially microorganisms with high adhesion properties to the to cellular walls. So some types of microorganisms would do this more often than others. Then the blood microorganisms, they adhere to the platelet surface, and the final step would be a sort of an infected clot, let's say, which is actually called a vegetation. And due to the fact that it is an active, metabolically active sort of structure, it can grow and attract more platelets, attract more microorganisms, and it can grow. And it is only when you use an antibiotic with high power, let's say, over that microorganism, specific microorganism, that you can make it stop to grow and maybe reverse the process. Due to this, the first, let's say, stage of the vegetations is of quite small structures on the valve, but we don't very often see it because it is a stage where the patient doesn't have many symptoms, the valve doesn't have many problems of competency, and therefore the patient is not coming to the doctor due to these very small vegetations. The patient might, however, have fever or some bad altered state. But for such a thing, they wouldn't come to the cardiologist. They would either go to the GP or maybe to internal medicine or maybe to infectious diseases. And the doctors that they see might look for their blood workup and find inflammation. And some doctors would very quickly say, let's give you an antibiotic. So these patients often go back and forth from a GP, infectious diseases, internal medicine. They receive antibiotics, and by the time they get to the cardiologist, the vegetation is much larger than what you see here in this image. Now let's see how we can classify infective endocarditis. You might have seen, those of you who are already in the clinic, and if not yet, you might want to know that every time that we establish a diagnosis of a patient, we try to make some order in the diagnosis, and we try to make it as clear as possible using various classifications in order to make communication easier with our colleagues, either colleagues from other specialties that see the patients, or our colleagues who are on call and they might get to see the patient late at night, and you want them to know exactly what the disease is. And for infective endocarditis, we usually don't just say infective endocarditis and that's all. We usually say if it's an infective endocarditis of the native valves, or if it's an infective endocarditis of the prosthesis. And we might also want to say on which valve. So we might say infective endocarditis of the native mitral valve, or infective endocarditis on the aortic prosthesis. Then we want to communicate on the way this endocarditis is achieved or was or appeared. And this can be just community-acquired endocarditis. You will learn more about this when you will have infectious diseases, but it's easy to understand that community-acquired is something that you just, you go around in your daily life and you get a sort of any type of bug of bacteria, or maybe you have a small lesion and it just enters your skin, and that's community-acquired. Or if it is a nosocomial infection, meaning it is associated with a medical assistance. So either the patient went to the dental medicine and they had an extraction of a tooth, or they had some other intervention, or they had surgery, or they had a tattoo, for example, and that is not really nosocomial, but it is still associated to something done by another person. And then through this intervention, there is an entry site of a microorganism in the blood. And IV drugs is another situation, a different situation. And the last way of classifying is the recurrence, because some patients have a recurrence of the endocarditis, and it might be the situation that if it's not the first episode, then you should ask yourself, could it be that the first episode was not correctly cured and this is just a continuation of the first episode, and that's called a relapse. And it's usually proven by finding the same microorganism and quite soon after the first episode, less than 6 months. Or could it be a reinfection, a different infection, just bad luck that the patient has it twice? It's usually more than 6 months apart, and it's a different microorganism. Also, depending on what type of valve and of situation we are in, the responsible microorganisms might be different. Saying that, for example, on native valves, the most frequently seen microorganisms might be from the Streptococcus species, mainly Streptococcus viridans, or from the Staphylococcus species, aureus or white. But it can also be that there are germs coming from the GI tract, like Enterococcus or Streptococcus bovis, or other types of various germs. You can see here just a part of the list. And we will discuss it a bit later. There can be up to 1/3 of the situations with negative hemocultures. On the prosthesis, however, things might be different, especially in the first year after surgery. Because in the first year after surgery, it might be that the infection of the prosthesis is due to germs that entered the heart together with the prosthesis. And these are germs that usually come from the skin, either the skin of the patient, or much more difficultly it would be that it would be from the skin of the medical personnel, but it could happen. If, of course, sterilization was not perfect. And that from the skin, those would be Staphylococcus species, white or aureus. But it could also be other germs from the hospital medium, like, for example, gram-negative bacteria, or it can be fungi, because these patients might be more immunosuppressed, and also it can be a sort of a nosocomial infection. If the infective endocarditis appears on a prosthesis but late after the surgery, the index surgery, then of course the germs would not differ from the ones that appear on native valves, because the entry site would be similar. In IV drug users, as you could, let's say, imagine, the main germs are those that are found on the skin, because they enter with the drug needle, and that's mainly Staphylococcus. But one of the characteristics of IV drug users would be that they can get polymicrobial infections, because if they have more punctures, then at each puncture they could get in a different germ. If there could be an infective endocarditis on the lead of a pacemaker or a defibrillator, as I was saying before, it's usually coming from an infection of the pocket site where the pacemaker is put. Maybe some of you already saw a patient with a pacemaker. So there is a small pocket that we perform in order to put the pacemaker in. And then, of course, the germ can enter if the asepsia is not perfectly done, which should happen. The patients already receive some antibiotics for this procedure. But if anything goes wrong, then there could be from the skin Staphylococcus again, white or aureus. And as I was saying before, what happens on the valve is mainly that these vegetations appear, and vegetations in turn can lead to a destruction of the valve, because they grow, and they don't only grow up, but they can grow also in the valve, and they can perforate it. They can grow so big that they could they could go against the opening of the valve or the correct closure of the valve, so they make it have an abnormal function. And they can also extend towards the annulus of the valve, which can lead in turn to an abscess, for example. Of course, vegetations being masses which are quite frail, let's say, due to the fact that it's just platelets and microorganisms or germs, they can break. a bit of it can break and they can embolize from the vegetation towards other areas of the body, like for example the brain or the kidneys or the spleen or peripheral limbs. So this is an important complication and physiopathological change. And then, of course, if we don't treat it correctly, there would be a continuous bacteremia, some sort of sepsis, and this can also lead to suffering of the organism. I have here a few still images just to make sure you all see it correctly. So these are zoomed images of the aortic valve and here as well. And you can see on this aortic valve there is a mass. There is something which shouldn't be here in the LV outflow tract. Here the same, there is a mass on the aortic valve. Here is a transesophageal echo. You know that from this sign on the corner of the image. And here, also in transesophageal echo, this is the mitral valve. And we see where the arrows are, two masses on the atrial side of the mitral valve, which are again vegetations. So these are examples of vegetations as we see them. And this again in transthoracic echo here on this side and on transesophageal echo on this side. This was the case of a young man known to have mitral stenosis, and you can see here the mitral valve and the sort of doming of the anterior mitral valve. So he was known to have mitral stenosis. And he came to the hospital with dyspnea at any sort of effort and fever. And what actually we saw was on the aortic valve, which was not known to be diseased, there was this vegetation. And when on a zoomed image, you can see it even better. It's a long vegetation. A sort of here it gets like a filament, it's thin. And also we can see it here and here there seem to be two regions of communication. And here we see there are two flows, jets in color, meaning that this vegetation might have perforated the aortic valve, giving a severe aortic regurgitation. And this actually corresponds to this, which is an aortic cusp perforation due to infectious endocarditis. And of course, the only treatment for such a thing is surgery, because you cannot do anything. I mean, antibiotics can, of course, sterilize the valve, but they cannot repair this sort of perforation. So how do the patients present themselves? What brings them to the doctor? It's very variable because, like any other infectious disease, they all sort of look alike up to a point. Even nowadays with COVID, we always suspect COVID in such a patient, but finally, if it is not the case, of course, we still have to remember that there are other diseases, even infectious diseases. Most of the patients, they have fever. Okay, very good, but fever, of course, is such a non-specific symptom that you cannot just think, of course, of endocarditis. However, if fever is present in a patient who has, at clinical examination, a heart murmur, especially if the heart murmur is changed from the way it used to be, or it's a new heart murmur, of course, depending on the fact that you should know how his auscultation was before, then it is a high probability of infectious endocarditis. It usually also comes with some signs of heart failure. It could be left heart failure with dyspnea. It could also be congestive heart failure with dyspnea and also edema and hepatomegaly. And as I was saying, the vegetations are quite frail and sometimes they can embolize. And you see here that up to 30% of them get to embolize and to send fragments in the periphery. And then you would get, of course, in the clinical picture, the signs of embolus. Like, for example, if the patient has an embolization to the brain, the signs would be signs of stroke. If the patient has embolization to the kidney, the signs would be lumbar pain, hematuria, or pyuria, which is pus in the urine, and this could raise the suspicion. If they have an embolus going to the lower limb, they could have signs of acute limb ischemia. The limb becomes cyanotic, very painful, very cold. So you could get the signs of systemic emboli. Of course, if a patient comes to you, you would be a GP or you would be any other type of doctor, and they say, I have had fever for a week now, and I'm quite short of breath. And since yesterday, I also have lumbar pain and my urine is not very clear. Of course, first you would think of pyelonephritis, but if you find out that the patient also holds, he's known to have mitral regurgitation for a few years, then you should think as well to infective endocarditis. And you should, when you think of it, begin to look a little more in depth at the patient. I know you are a very unlucky generation of students because last year when the pandemic came, you were in the middle of your semiology training, and now it goes on and we cannot really show you so many signs and symptoms and auscultation and everything else. But at least with these online lectures, we hope to make you aware of these sort of signs that you should look for in patients, meaning that the patient should not only be sent, for tests like blood tests or echo or CT, MRI, fancier and fancier, because of course, you have to use those as well, but you should remember to examine the patient. For example, in infectious endocarditis, there are several signs on the skin which are very helpful in making you think of endocarditis. And just here you have a few. You have the splinter hemorrhage in the nails. So if you see one or more nails with this sort of hemorrhage, and then everything else, the fever, and there is no traumatism explaining it, think of endocarditis. If on the palms or the plants of the patient you see this sort of lesions, again a bit hemorrhagic and non-painful, they are called Janeway lesions, think about endocarditis. If the patient comes to you and says, I have had for a few days now some nodular lesions on my palms usually, and they are quite painful, they are red and it hurts me, and then you have the context, some fever, something else, think about endocarditis. If you are an ophthalmologist, for example, and the patient comes to you and you see these sort of, it's called the rot spots on the retina, which is again some sort of hemorrhage, and maybe also you see this sort of conjunctival hemorrhage, just have in mind that this can appear in infective endocarditis. The patients can also have this sort of clubbing, but this is not very specific. Maybe in patients with very long standing endocarditis, they can appear, and the mechanism is not very well known because it's not similar to those in hypoxia, long standing hypoxia. And then you have these symbolic manifestations, which can, of course, as I said before, present as signs, clinical signs, and I mentioned them just before. Another complication, very, again, dreaded complication of infective endocarditis are the mycotic aneurysms. What are these? They are the effect of embolization of septic embolization in what is called the vasa vasorum of the different vessels. So the small vessels that bring blood to the vessel wall. and meaning that there is a septic effect on the vessel wall, it gets thinner, it gets frail, and it gets aneurysmal. And the aneurysm will grow, and by growing, there is a high risk of rupture. And this is very severe, mainly if the mycotic aneurysms are in the brain, because they get a hemorrhage that is usually fatal to the patient. We were talking about the fact that these vegetations can give severe complications like perforation, for example. I was talking to you about abscesses. And here you see an example of an abscess in the interventricular septum. And when you think that here, up in the interventricular septum, at the basis of the septum, there also is the atrioventricular node and the beginning of the branches, the bundle branches, then you might imagine that when a patient has such an abscess, they might develop AV block, because the abscess is blocking, is interrupting the electrical conduction. Much more rarely, you could have such a huge vegetation that obstructs the valve, but this is very rare, and such an image is mostly seen with tumors like myxomas. Now, what about the paraclinical tests that we can use? Of course, you are used by now to the fact that the first test we usually, the first type of test that we usually discuss are the lab tests. And in the lab tests, we would first mention the inflammatory syndrome, because of course it's an inflammatory and infectious disease. And this means that the patients usually have a high leukocyte count, but sometimes they can have low leukocytes if they are in a sort of very severe state, because their bone marrow might not be able to create any more cells. Like, for example, they can get anemia due to that, and the platelets might be high or might be low. So this is quite non-specific, but it's usually an abnormal hemogram. The other inflammation parameters like fibrinogen, C-reactive protein, erythrocyte sedimentation rate, they all are abnormal. It's completely unusual to have a normal test among these. Procalcitonin or presepsin are parameters of sepsis, of bacteremia. So they are usually positive, but they might be negative in patients who received already some antibiotics. The renal function might be normal, but if there was a renal infarct, a renal embolism, or if the patient received already antibiotics which give renal toxicity, like for example gentamicin, which is quite used in endocarditis, they might have renal dysfunction. And you might, as I said before, find various degrees of hematuria, for example, due to emboli or to an immune glomerulonephritis that can also appear in endocarditis. There might also be some tests which are abnormal, like rheumatoid factor, it might be positive, the serum complement might be decreased. These are just the effects of the immune fight of the organism to this. Of course, we always want to know which is the germ that provoked the endocarditis. And in order to find that, we should obtain 3 hemoculture sets, at least 3, usually 3, which means we take blood and we put it on growth medium to see if any type of germ grows there. It's best to take them from different veins, different sites, so that there is no interference with the presence of a germ on the skin near to the same vein. And they should be taken at a small difference in time, around 30 minutes, so not just one after the other, to let some time for the bacteremia if it's not maximal or at the peak at that the first time of drawing the blood, it still has time to appear. There should be enough blood, around 10 milliliters. And the cultures should be prepared for aerobic, for anaerobic cultures, because the germs might grow variously. And we should let the cultures grow for around 2 weeks, because there are germs with slow growth. And if we just, stop following the media after, let's say, 7 days or 5 days, we might see nothing. But still the germ would grow a bit later on, a few days later. So don't forget that this should also be followed for 2 weeks. And as I said, we should know if the patient received already antibiotic treatment or not. However, and I mentioned it before as well, there is quite frequent, when you think of 30%, this is a high percentage, that the patients don't have any germ growing on the hemocultures, even if many other criteria, many other elements make us be quite sure this is an endocarditis. We see the vegetation on the valve, there is high inflammatory parameters. The patient has fever, maybe even has osseous nodes or Janeway lesions. But still, when we grow the hemocultures, we follow them for 2 weeks, there is nothing growing on any hemoculture. And then we should think of contacting the lab, talking to the microbiologists about the possibility of having atypical bacteria with special forms of growth, intracellular growth, or fungi, which require special growth media. It also can be caused by the fact that the patient had some antibiotic already, which made the growth of the bacteria maybe slow, but usually without sterilizing, because we usually look at this due to the fact that the patient still has symptoms. And then there are other germs which can give endocarditis, which do not grow on media, but you need to do a serology. And you have here some examples: Coxiella burnetii, Aspergillus, Legionella, among others, Mycoplasma. And you have here a table with the proposed diagnostic methods, lab methods for these germs. And it usually either serology of the antibodies or, for example, PCR, polymerase chain reaction of the material if we already took out the vegetation, and we can cultivate and check for the germ in the vegetation itself. Sometimes, however, there might be that we test for everything possible in the best lab in the world with all the technical capabilities and good doctors, but we still don't find any germ. And if this is the case, one thing that we should take into account is that there is another disease which mimics very well infectious endocarditis, and this is called Liberman-Sachs endocarditis, and it's a non-infectious endocarditis. The vegetations are only thrombotic, they don't have germs inside, and it's usually associated to a disease that is called antiphospholipid syndrome, which can be associated to lupus. Lupus is a disease made very famous by Dr. House. Dr. House had this famous quote saying, it's never lupus. However, lupus is a disease that can mimic many other diseases, and it can often be lupus. You'll learn about it in rheumatology later in your courses. And in lupus or in antiphospholipid syndrome, which can be tested using these tests that you see here, antinuclear antibodies, anticardiolipin antibodies, antiglycoprotein antibodies, then it can give these non-infectious vegetations. And this is just a graph from a paper in which the authors checked on more than 700, almost 800 patients with endocarditis and negative hemocultures. And when they went very, far away with their testing in the lab, they found another almost 500, so 2/3 of these patients at the beginning not having etiology, actually they found the etiology. It was either Bartonella or Q fever or Treponema whipplei or fungi, so germs that grow more difficultly in the cells, need serology and so on. So again, the message is, if the hemocultures are negative, don't just say, okay, it's a negative hemocultures endocarditis, but really make sure that the tests were as thorough as possible. Then, of course, we go to the more specific cardiologic testing. The ECG is not very informative. Of course, it can have abnormalities, but they are not in any way specific to infectious endocarditis. Because of the fever, the patients often are tachycardic. They have 100 beats per minute or even more. They might have conduction disturbances. I described you the fact that if an abscess occurs in the interventricular septum, for example, then there might be AV block or bundle branch block. They might have ventricular arrhythmias due to embolisms, but it's completely non-specific. Another thing that can be used, of course, is by using imaging. And imaging, especially echocardiography, is pivotal in the diagnosis and, of course, also in the follow-up of patients with infective endocarditis. And it's also, as you very well know, the main technique that we use in these patients. And I think more than the theoretical part of echocardiography, what you should get more familiar with are examples or images of echo. But just to remember, the major echocardiographic criteria in echo are the vegetations that I showed you, the abscess or some other form of abscess, which is called pseudoaneurysm, and if mechanical prosthesis is present, the dehiscence of this prosthesis, and this you might see more in the prosthesis, valvular prosthesis lecture. Sometimes echo does not see the vegetations, and this might happen if there are a lot of calcifications in the valves, if there is a mechanical prosthesis which might have some artifacts in echo, or if the vegetations are very small. And here you have a list of the various structures or abnormal findings with echo. So vegetation, abscess, pseudoaneurysm, which you will see just in a minute as an image, which is a sort of perivalvular cavity which communicates with the lumen, a perforation of the valve that I showed you before, a fistula, which is actually a communication between cavities due to the perforation, but not of the valve, but of a wall. A valve aneurysm is something more rarely seen, is sort of a precursor of the perforation. And as I said, the dehiscence of the prosthetic valve, which means that the prosthesis is sort of decollated there where the infection made the suture sort of melt, let's say. And here you have some images. And now I'd like any of you, if you want, to tell me what you think is wrong here. Does anybody have the courage to answer? I cannot hear you. Are you still on?
The mitral valve has an abnormal movement and
Okay.
also a
Very
shape,
well.
the shape of the mitral valve.
Okay, very well. So what is you think actually wrong? Meaning, what do you think is on the mitral valve? I'll put it again. So I think here in the image up, which I think you see moving, there is something wrong with the posterior mitral valve. This is the valve. Normally it should co-opt with the anterior valve. They should close like when we are clapping our hands. But what actually happens is that this valve goes up in the atrium and it has on the valve some structure. It has something which is a bit thick, is a bit hyperechogenic. And here in the apical four-chamber view, we see again that there is a mass, something with maybe even more little structures on the valve that should not be here absolutely. And then down here on the color image, I hope you see, there is a big jet, a very turbulent jet. This one, I'm showing it, the blue one, which is mitral regurgitation. Do you see it? Does everybody see it? I would need some confirmation of the fact I'm not talking alone.
Yes.
Yes, we can see.
Yes, we see it.
Okay. So this is a clear infective endocarditis of the mitral valve, mainly, at least on these images, we might be quite sure that it's on the posterior mitral valve. And the effect of this endocarditis is severe mitral regurgitation. Okay. Now, another case. Here it's a transesophageal echo, so I don't necessarily ask you because you might not know exactly the orientation of the images. So I was telling you that if you see this this sign here in the corner, it means it's a transesophageal echo. And here is the left ventricle, left atrium, and aorta. And here is a zoomed image. And here is the aortic valve. And I hope that you can all see that here on the ventricular side of the aortic valve, there is some filamentous structure. It's actually not only filamentous, I stopped it now. It has a first part which is thicker, and then there is something long attached to it. You see it sort of floating in the LVOT. And the effect of this vegetation, because it's a vegetation, that the patient also has a severe aortic regurgitation, and you can see it here. Let me try. You see this sort of greenish jet, which means there is a lot of turbulence. It's a sort of mosaic, actually. It's not only green, it's green and yellow and red, which goes well with aortic regurgitation. So it's a vegetation which gave some destruction to the valve, and the effect was the regurgitation. This is another case, and if you look at this image, the movie actually on the left side, you can see again transesophageal echo, and here it should be the aortic valve. It is the aortic valve, and there are some white spots. These are the calcifications, but what is mostly abnormal is that there is this sort of pouch. You see it? And you see it better here on the zoom image, the fixed one, this sort of pouching. It should not be there. There appears that the blood goes into it somehow, and this is an abscess. This is the sign that the infection went inside the tissue of the aortic annulus and formed this abscess. And the very bad thing about abscesses is that when you give antibiotics, they might sterilize vegetations on the valve, but they usually are not able to sterilize the abscess itself because they don't enter very well there. So this is an aortic annulus abscess. And here you have the just the depiction exactly of the limits of this abscess. So echo, and especially transesophageal echo, is a marvelous method for helping into diagnosing endocarditis. But of course, we have more and more imaging techniques. We'll actually have together a lecture on imaging techniques other than echo. And some of these are here. One of these is CT angiography. We don't really use it to see
I'm sorry, Professor.
Yes?
We cannot see the presentation. Like we have the.
Okay. And this is for a long time it happened? Because I hoped you are seeing what I'm showing you. Let me see. Do you see this now that we went through with the aortic vegetations? Can you see the movies?
No. I mean, I
More
cannot.
mitral vegetation.
With the big mitral one?
Oh.
That's the last one you saw? Yeah, okay, but okay, you should have told me. Let me reshare then, because I don't know why this happened. Wait a minute, I'll just I'll share the slideshow, but I'll just, okay, because it's a pity there are nice movies, and let me reshare it. I hope it will work again. Okay, what do you see now? Do you see some movies?
Yes.
Yes, and this is the vegetation that I was describing on the aortic valve. Okay, so this is a filamentous, a long vegetation. Here you can see it floating, sort of. There is one that appears to be thicker at the beginning. This is the aortic valve, and then there is a longer filament, and it gives here on the color Doppler image aortic regurgitation. So this was one example. Now I moved on another slide. Do you see again a new slide called aortic abscess? Can you see it?
Yes.
Yeah.
Yes, okay. So now what you see here, and I'm showing you again because I understand you didn't see it, is that you see this sort of pouch near the aortic valve here, and you see it better on the zoom image. You follow the arrow. This is a sort of abnormal pouch. It shouldn't be here. And here you can see the delineation of this pouch. And this is an abscess of the aortic annulus. And it is a firm indication for surgery, because antibiotics are not able to go well inside and sterilize it. And now I was here. I was telling you that CT angiography, we don't use it to see the vegetations. We use it either to see the coronary arteries, and we will learn about it in the imaging modalities lecture later in your stage. But also we can use it to see abscesses or pseudo aneurysms, and I will show you some images. For example, this, I hope you now see this slide with the pseudo aneurysm. Just say short yes, so that I know I'm not describing it. Thank you. So here is a patient with aortic stenosis. Here in the movie, it's another transesophageal echo. You can see the structures here. So left ventricle, mitral valve, aorta here, and this is a pseudoaneurysm, again a pouch which should not exist here. And with a small communication, if you see it is like a small door, and it's sort of moving a little. And this is the communication of the pseudoaneurysm. But with echo, we only see this part of it. We don't see it completely, let's say. And CT was able to describe exactly the extent of this pseudoaneurysm. This is a CT image here, and here is a very beautiful 3D reconstruction of this pseudoaneurysm. You can see it here near the aorta. So it's a sort of outpouching from the aortic annulus. The blood can enter it, and you see it here in the color Doppler image, but it's still a severe complication because, of course, it's a structure, an abnormal structure, and it can fissurate, it can break, and that can be fatal for the patient. And Another imaging technique that can be used is nuclear medicine. And it begins from the concept that in nuclear medicine, we can see spots that are like hot spots that are very active from the metabolic point of view. This is the principle behind using, for example, PET-CT in cancer, because the tumors are usually very metabolic active. They want to grow and to take over. But of course, also the infectious sites, the germs inside the vegetations or abscesses are usually also very metabolic active. So you can use either SPECT or PET-CT to see, for example, around the prosthesis here, an aortic prosthesis, there are hot spots suggesting that there can be an abscess here, a periprothetic annulus abscess. So it shouldn't be so hot, it should be just a normal sort of region. Okay, in the end, we have done everything. We have done the echo, the lab test, the hemocultures, maybe a CT, and we have to end our workup by saying or by answering the question, does this particular patient have endocarditis or not? And in order to do this, not very easily, as you can see, we use what is called the Duke modified diagnostic criteria. And this is an excellent exam topic. So remember that you should know it. It might come up either in the written exam or in the MCQs. So we have several criteria. You will see it. There are major criteria and there are minor criteria. And if the patient has 2 major criteria, or if the patient has 1 major criteria and 3 minor criteria, or if the patient has 5 minor criteria, then the patient has definite endocarditis. In the other combinations that you see here on this slide, like for example, 1 major and 1 minor criteria, then it's called possible infectious endocarditis. And then you may want to go on with investigations to add more criteria if possible. And in the end, if there is a firm alternate diagnosis, so for example, the patient has fever, they have an aortic stenosis, but they also have, pyelonephritis or pneumonia or COVID, for example, then it's called what is called a firm alternate diagnosis. We have another explanation for the fever, then we sort of rule out. We say it's a rejected diagnosis of infectious endocarditis, and so on. So now let's see which are the major and which are the minor criteria. There are 2 sets of major criteria. The first one, it's related to the blood cultures, and the second one is related to imaging. So the first one, the blood cultures are positive for infectious endocarditis. So we give the hemocultures and they come back from the lab as positive. But it's not very easy always, because they should not only be positive, but they should have some rules with them. So they should be positive with some sort of typical microorganisms. And I mentioned them before: Streptococcus viridans, Galolyticus or bovis, Staphylococcus aureus, the Hacek group, some other Enterococcus. So there should be some germs that are known that they adhere to the platelets. So they have this ability of adhesion to cells, to other cells. And they should not be only 1. For example, we drew 3 hemocultures, and then we get it back that 1 is positive and the 2 others are not positive. This is not enough. There should be at least 2 blood cultures that are positive. With imaging, what is a positive criteria, a major criteria? We see the vegetations. I showed you some images. So if you see such a vegetation, then you have 1 major criteria. Or we see the abscess, or we see the aneurysm, or the perforation of the valve, or we see the dehiscence of the valve. And then also with imaging, we also can use as a positive criteria this positive PET-CT or SPECT-CT at the site of prosthetic valve, or cardiac CT showing a paravalvular lesion, like for example, a pseudoaneurysm or an abscess. So any of these, if you find it, is a positive, a major criteria. So if you have the good type of hemocultures positive and the vegetation, you have two major criteria, is perfect. Then the diagnosis is definite. But maybe the hemocultures are coming out negative and you see the vegetation. Then the patient should have at least 3 minor criteria. And what are the minor criteria? There are 5 types, so 5 sets of minor criteria. One is to have a predisposing heart condition or to be an IV drug user. So if you already are known to have mitral valve prolapse, for example, then there is a valvular heart disease which might predispose to endocarditis. The second minor criteria is fever, more than 38, not 37 to 38, but more than 38. The third diagnostic criteria is the presence of what we call, put it in a bucket, vascular phenomena, which might be embolization of any type, including the mycotic aneurysms, and the ensuing intracranial hemorrhage. The conjunctival hemorrhages and the Janeway lesions are also considered a vascular phenomena. 4, the immunological phenomena. There might be a glomerulonephritis. I was telling you at the lab test that this can happen. It's an immune glomerulonephritis. There can be the presence of oscillar nodes or rot spots. This can be immunological phenomena. Also, a positive rheumatoid factor, which is sort of false positive, it's an interference between tests, can be an immunological phenomena in endocarditis. And the last minor criteria can also come from the hemoculture. If the patient has positive blood cultures, but only one maybe, or several but with atypical microorganisms, then it's a microbiological minor criteria. So any hemoculture finding which is not consistent with the major criteria. And then we, make it like a list, a checklist, and based on the number of major and minor criteria, as I said before, we say, is it a definite endocarditis? Is it possible endocarditis? Or is it just not endocarditis? We reject the diagnosis. And here you have another way of putting this sort of diagnostic algorithm with the various criteria and then how we end up with a diagnosis. Of course, after we have a diagnosis, it's very good, but we have to choose our treatment and we have to think, how is the prognosis of this patient? Will this patient probably survive, or is this patient very high risk? And then we have to treat more aggressively, meaning we have to go quickly to surgery, or we have to give all the antibiotics possible in the regimen. Of course, as you will see, there are several regimens of antibiotics. So very high risk are usually the patients who have symptoms and signs of heart failure. It means that there is not only an infection, but the infection affects the heart structures and gave maybe a severe regurgitation or something that obstruction of the valve. Staphylococcus aureus is a very aggressive germ. It can attack not only one valve, but all the valves or several valves. The presence of abscesses is also a sign of severity. Because it can lead to other complications like fistula or AV block, as I said before. Then other patient characteristics that go with bad prognosis, of course, older patients or diabetic, patients that have other diseases as well that can go with each other. Patients who have renal failure or pulmonary disease. So all this can go with a bad prognosis. For the medication, you will have to sort of be a geek for the exam and just learn it by heart. We all did it for exams. Of course, we are luckier in clinical practice because we can, just check it on a smartphone or in the guidelines and go back to it. Because the regimens of antibiotics in endocarditis are quite complex. So what you have to remember as a general rule is that the antibiotics have to be given in high doses with a long duration, and we only use bactericidal antibiotics because maybe from pharmacology that there are also antibiotics which are like bacteriostatic antibiotics and which can be enough in other diseases but not in endocarditis. The regimen of antibiotics depends on the type of germ. So as you see here in this table, if it's a Streptococcus bovis group germ, then you might use, for example, a combination of penicillin, sorry, not a combination, you can use either penicillin, less often used, or amoxicillin or ceftriaxone. The doses are high because, for example, for penicillin, a dose of 12 to 18 million units per day is a very high dose. Usually we use in other infections maybe 1 or 2 million units per day. You can, in patients who are very good prognosis, non-complicated, native valves, normal renal function, you can use 2-week regimen because in other cases we use 4-week therapy, or if it's prosthetic valve disease, the table in the guidelines very nicely says 6 weeks. This is the usual treatment duration. 4 up to 6 weeks is a very long antibiotic treatment. For Staphylococcus, for example, we give around usually 4 to 6 weeks of oxacillin, for example, 12 grams per day, or in patients who are penicillin allergic or they have what is called an methicillin-resistant Staphylococcus aureus, you give vancomycin as the main therapy. With prosthesis, you have to give an association of antibiotics because, again, with the sutures and the risk of abscess, there might be a need for even stronger antibiotic treatment, and then you can give either oxacillin plus rifampicin and gentamicin, or in methicillin-resistant Staphylococcus or allergic patients, vanco plus rifampin and gentamicin. So again, not an easy treatment, and you see here for prosthetic valve it can be even more than 6 weeks, at least 6 weeks. Then of course you might ask, okay, but what do we do until we know which germ is responsible? Because you said the patient comes, it's a severe disease, we draw the hemoculture, but you said that, I said that the hemoculture might grow in 1 week or in 2 weeks. What do we do? Do we just stay and wait, sit and wait and look at the patient and give maybe some, antipyretic drugs? No, definitely not. And this is what is covered by what's called the empirical therapy, meaning we give antibiotics based on the probability of the type of germ that we might find. And based on this probability, if it's a native valve and it's community acquired, that's why it's important to know and to have thought of this, we will give, for example, you see it here, ampicillin and oxacillin and gentamicin, which makes a regimen covering for most of the possible germs, Streptococcus and Staphylococcus family. If it's late prosthetic valve, I said at the beginning, it's usually with the same germs and as native valves. If it's prosthetic valve endocarditis, but it's early, or if it's a nosocomial native valve endocarditis, then we have to give a strong regimen, including vancomycin, gentamicin, and rifampin. So just a strong regimen. And again, it's usually up to 6 weeks of therapy. But for the empirical therapy, it's usually we give it until the hemocultures come. And if the hemoculture come, for example, with Staphylococcus, as is the table before, we switch to the Staphylococcus regimen. Normally, a patient who has a good response to treatment should have in less than a week no more fever and blood cultures become negative. But if the fever persists, then there might be a problem. The problem might be that the infection is not controlled, either because we didn't choose well the antibiotics, or because there is an abscess, for example, or a septic embolism in another organ, and then the antibiotic just doesn't enter well and isn't able to sterilize this sort of tissue. And another problem that we should follow for is renal function. Not only because the disease itself can affect renal function, but also because the patient, the antibiotics, especially gentamicin that you saw, might affect the renal function. For many patients, not all, but many patients, there is need for surgical therapy. It might be that patients need urgent surgical treatment, or they might need non-urgent, deferred surgical treatment after the antibiotic was efficient already. Because we like and surgeons prefer that the patient is operated on in sterile tissue. Because if there is an infection still in the heart, you put a prosthesis and there is a high risk that the prosthesis gets infected as well. So usually the surgeon prefers to do the surgery, the operation, after at least 2 weeks of good antibiotic treatment, and optimally at the end of the antibiotic treatment, so 4 to 6 weeks. But sometimes it's not possible because, as I said, there might be a need to emergency within 24 hours or urgent surgery within a few days. And this is mainly, as you see here in the table, the timing of emergency or urgency is dictated by, for example, heart failure due to severe regurgitation, due to obstruction of the valve, the presence of abscesses, which is a sign of local uncontrolled infection. Also, fungi or multi-resistant organisms would be an indication for surgery because, of course, they would not get much response from antibiotics. So there are these situations you can see here that are linked to either urgent or emergency surgery. Another situation is the very big vegetations, because the biggest the vegetation is, the biggest the risk of embolization. And I'm ending the lecture by just mentioning an important issue, which is the fact that knowing that infective endocarditis is such a severe disease, we prefer that patients don't get it. And of course, this is true for any diseases that you might learn. In infective endocarditis, knowing which are the categories of patients mostly at risk for endocarditis, we can use some prophylactic methods. And the prophylactic methods evolved a lot during the last 2 decades. And of course, you should now know which are the current indications. And the current indications are, let's say, restricted to patients at very high risk, at high risk. Who are these patients? The patients who are at high risk to get endocarditis, to have endocarditis, are the patients with a prosthetic valve, mainly prosthetic valves, implanted percutaneously or surgically. The patients who already had once or more times endocarditis are very high risk to have it again. And also the third category is the patients with congenital heart disease of a cyanogenic type, you will learn about this, and which is uncorrected or has a palliative shunt. So these are the 3 categories of patients needing endocarditis prophylaxis. There are some non-specific prevention measures, not antibiotics, just some things that you should teach the patients they should take care of. Like, for example, strict dental and cutaneous hygiene, knowing that the germs can enter the blood if the patient has parodontosis, for example, and there is a lot of bleeding of the gums, and then you should tell the patient that they should have a good dental hygiene, dental checkups, everything like that. If they get a wound, if they have they are at risk and they have a wound, they should have very careful asepsia of the wound. They should limit their venous catheterizations, blood drawing, invasive procedures, because any of these procedures has a high risk of germs in the blood. And as funny as it might seem to include this, in patients who are at high risk, we should discourage tattoos and piercings, because that can become a sort of passion for young people. Young people with cyanogenic, uncorrected congenital heart disease might want to be, modern or like their friends and then get a tattoo or a piercing. But that, of course, is a procedure which, even when done in good shops, tattoo shops, or can have a risk of bacteremia. So they should, know at least what is at stake. And the most frequently seen situations when a patient has endocarditis and you ask, did you do something with, which could put you at risk, surgery or a piercing or whatever, but the most frequent answer is, I went to my dentist. And of course, you should go to your dentist. But if the dentist makes an extraction, dental extraction, and there is no antibiotic, as you will see, and the patient is a high-risk patient, there is high risk for endocarditis. The good way, the right way of doing it is you go to the dentist. If you are a high-risk patient, you have to take care of your teeth, but at any time that the dentist says, I call you for an extraction, or I call you for something with working on your gums, or it can have some bleeding, there can be some bleeding, then the patient has to take antibiotic prophylaxis, meaning that half an hour to 1 hour before the procedure, the patient takes the antibiotic, and the easiest one is, if they are not allergic to penicillin, is amoxicillin, for example, 2 grams orally usually. It's just the patient needs to know, because sometimes the dentist might not ask, and the dentist might not know that the patient is at risk. It is the cardiologist who should tell the patient, you are a high-risk patient for infective endocarditis. Every time you go to your dentist for some procedure with the risk of bleeding, you should know and take amoxicillin at most 1 hour before. And you see there are also possibilities for children, other doses, or for patients who are allergic to penicillin. And to end my lecture, I think you got to understand that it is not always easy to manage this disease. And it is a disease which, even by guidelines now, needs to be managed and addressed by a multidisciplinary team. Because together with the cardiologist, in close collaboration should work the microbiologist for the lab, for the hemocultures, the infectious disease doctor, a cardiovascular surgeon, because there might be that often patients get to cardiac surgery, neurologists and neurosurgeons, if there are cerebral complications like mycotic aneurysms, mycotic cerebral abscess, or cerebral intracranial hemorrhage. So this is to conclude this lecture, and I hope it convinced you that it is a disease first, it's very important to have the suspicion in order to diagnose it timely, early enough in the evolution of the disease. And it is a disease that needs a very attentive and quite complex therapeutic approach, including antibiotics and cardiac surgery. And now it's your turn to tell me if you have any questions or comments for this lecture, if there is something you didn't understand just by listening to it, or if it's all clear for now.
I think it was all clear. Thank you.
Okay.
Yes, thank you.
If you have any questions, you can tell me. We'll have other lectures together, or you can mail them. Okay.
Yes, thank you so much.
Thank you for being here, and see you again.
Thank you.
Thank you. Have a nice
Bye-bye.
day.
Bye.
Bye.
Bye. And